Good evening, all. A journal club is a gathering of academically interested doctors who regularly discuss what's new in the recent literature and landmark papers. Today, 1st December, we have successfully completing the year 2022 with yet another episode of academic excellence, and the topic is to stimulate your gray matter. What is it? Let us know from our MOC, Dr. Swati Hande. Over to Dr. Swati.
Thank you, ma'am. Good evening, everyone. On behalf of IIP Raigad branch, I invite you for yet another new edition of Journal Journey, venturing into the field of rheumatology, which is a rapidly expanding branch of pediatrics. I welcome all the dignitaries, chief guests, experts, presenters, and all the colleagues who have joined the session. I would now like to request Dr. Pramod Hemant Gangolia, sir, Maha-IIP President, to share his thoughts and make the opening remarks for the ceremony. Over to you, sir.
Thank you, madam. Good evening, respected dignitaries on this Zoom dais. We have today our chief guest, Dr. Nimed Mohanty, sir. Probably he is a mentor, he is a good academician, and he is a guide for us, under whose these thoughts we started this journal journey on Doctor's Day in 2020. 21, and this is going on since last 1.5 years. So एक लाइन काफी है सर के लिए, बहुत ही अच्छे इंसान है, a very excellent human being. That is his introduction. And of course he's a emeritus professor at MGM Hospital, Navi Mumbai, but he's a very really good friend and mentor and guide. Our guest of honor as well as today's expert is Dr. Pawan Kalyan sir, who is a Honorary Secretary General of Andhra Pradesh State. He is a great academician. He is a pulmonologist, sleep specialist, and an excellent academician. Welcome, sir. As well as we have good, excellent moderators, Dr. Chitra Kulkarni madam, as well as Dr. Swati Hande madam. Dr. Chitra Kulkarni, what to describe her? She is just has taken all the efforts since the first episode of the journal journey, and it's very nice to see that it has started, which started from district Raigad of the Maharashtra state, went all to the regions of the Maharashtra state, and then it went to the west zone, Gujarat, Goa, and then we crossed the borders, went to the Telangana, and this evening we have Andhra Pradesh state with us in this journal journey, a great journey which probably will go ahead more vigorously. As well as excellent presenters, Dr. Raju sir, as well as Dr. Uday sir, who will be giving the deliberations. And yes, my right hand, Dr. Amol, Honorary Secretary General of Maha-IIP, my left hand, Dr. Jay Bhandarkar, the state convener, as well as Dr. Neha, who is all the efforts she takes in all crystallizing the slides and everything, messages drafting. So as well as, because I've joined through mobile, I cannot see everybody. So all office bearers of Maha-IIP, all office bearers of Raigad IIP, and my president, Dr. Pramod Wankhede sir, welcome to this session, and probably we will learn lots of things. Also, another expert, we are having Dr. Reena Jai Bhai from Navi Mumbai, rheumatologist. So we are having 2 experts and 2 presenters. So I think so we will have a good session and we'll learn more about rheumatology and wish each one happy learning. Thank you, madam.
Thank you, sir, for your kind introduction and warm welcome of all our guests for today's session. I now request Dr. Pramod Wankhede, sir, President of IIP Raigad branch, to share his thoughts and guide us further. Over to you, sir.
Thank you, madam. Thank you very much. Today's respected guest of honor, actually really honor to this chair that Mohanty sir is honoring as a guest of honor. So really, I'm delighted to see this. because sir is the main pillar of this journey. On this journey, where the wheels are resting on it, or rather running on it. And today's expert, Dr. Reena Madam, rheumatologist, Dr. Pawan Sir, pulmonologist, our presenter, Dr. Swas Raju Sir, Dr. Uday, our MahaIP Dynamic President, Dr. Gangulia Sir, Dr. Dynamic Secretary, Dr. Amol Pawar, Jay Vandarkar, Dr. Chitra Madam, Moderator, Swati Hande, my Dr. Vikas More and Dhananjay Rajput. I welcome you all. Probably this is the last episode of this year, I think. And probably next year, I'm sure that Raigad IIP will continue to take this journal journey ahead, and along with MahaIP. Only thing is there will be some change in body, but I will recite one stanza of one song. बदल जाए अगर माली नहीं होता चमन खाली बहारें फिर भी आती है बहारें फिर भी आएगी. Even if the body changes, continue all. So I wish that this journey should never end, and I wish the best of luck to this program. Thank you very much. Thank you.
Dr. Pramod Bhai, probably you may be continuing. I think so, hope so. But we at the same time, on behalf of MahaIP, I would like to welcome Honorary President of Andhra Pradesh State, Dr. Muralidhar Reddy. Welcome, sir. We would like to have your words also whenever the moderator asks Dr. Swati Madam. Welcome, Dr. Muralidhar.
Thank you, sir. I am honored to be part of this.
Yeah, sir, will you please share few words of blessings for this journal journey?
Sure, ma'am. Hello.
Yes,
yes,
Hello.
sir.
Yeah.
We are hearing you.
Yeah. Thank you, sir. I'm actually it's a very a very innovative thing to say. Completely unexpected, innovative, because the way that you are doing it, I think no other state has done this before. It's a very beautiful thing. I wish you all the best, sir. Please continue with this.
Thank you very much, sir, because you just invited an 11th hour, you graced the occasion. Thank you very much, respected our invitation. Thank you very much, sir.
Thank you, sir.
Thank you, sir, for your blessings, and thank you, Wankhede, sir, for welcoming all our dignitaries for today's session. Now, I would like to request Dr. Neha Singh, MahaIP editor and Raigad IIP member, to welcome and invite our chief guest, Dr. Niman Mohanty, sir. Over to you, Neha.
Thank you, Dr. Swati. I would like to welcome our Honorary Secretary, Dr. Amol Pawar, sir, to say a few words before that. Amol, sir, kindly share your.
Yes. Thank you, Neha. This has been a very great journey with Raigad IIP since last 11 months, and we are just starting the 11th episode of this year. And I think next body of Raigad IIP will also continue the liaison with MahaIP to have this journal journey ahead again in next year also. I thank President Wankhede sir to share this journal journey sessions with MahaIP, and I thank Gangulia sir, Jai Kumar sir for this very innovative idea, and Chitra Kulkarni ma'am is there always for this journal journey, coordinating the things. I thank Andhra President and Muralidhar Reddy sir, then Pawan Kalyan, my dear friend, for joining in today's session. Thank you, Niman Mohanty sir, also for your guidance throughout these 11 episodes. Thank you one and all.
Thank you, Amol, sir.
Thank you. Yeah, thank you, Amol, sir. Now I would invite our guest of honor of today, Dr. Niman Mohanty sir. He is Professor Emeritus Pediatrics from MGM Institute of Medical Sciences. He was also member of Academic Council and Advisory at MGM University and Health Sciences, former DIG Medical and Chief Consultant Pediatrics. He is recipient of Meritorious Service Medal from the President of India. He has 5 special duty medals with PAS, 2 commendation discs from CRPF. He has gone under advanced courses AIMS, PGIMR, at NIHM, IIT Mumbai, and NIDM. He has several presentations, publications, author in book chapters. He is scientific advisory and chief editor-in-chief in Indian Journal of Pediatrics. He is national convener of IIP ORS module Diarrhea TOT, ISPGHN TOT, and NEO PIA CON and Nutricon. He is life member of IIP, PIA, NNF, ISPGHN, and NYCF, NASPGN, NIFP. Welcome, sir. Over to you, sir. Kindly you give your blessings and your guidance. Sir, you are unmute. Kindly unmute, sir.
Sir, you are mute.
Hello, is it? Hello?
Yes, yes, sir.
Okay. See, I am in my house, so need not be a guest here, but I am really thrilled to be here today. This journey started with Jay Bhandarkar, Hemant Gangolia, sir. They requested me, let us have a new innovative idea. I have this journal journey. In our PG days, this journal day has to, in good institutions, some institutions, they hold it very seriously, regularly, religiously. In some other things, we try to skip this because the obvious reasons. But the idea of taking up this here in our IIP IGAD was to sensitize our practicing pediatricians about the evidence medicine, what is going on from day-to-day basis. Because normally, because of busy schedule, we don't have time to go through the journals. If in a month, if you are searching for 5 or 7 articles to choose one paper for yourself, at least in that process, you read so journal articles. But this year, like COVID we had, it spread so fast all over India. This journal journey of Raigad, in no time, it spread to all over the country. And I'm grateful, I'm really thrilled to know that this is being appreciated all over. Thanks, everyone. We'll go ahead with this journal study further also. The idea is today you will see, so slowly we started with very smaller, simple articles. Slowly we're building up to the more scientific and hardcore articles for obvious reasons that at least you will see that these kind of diseases which we are presenting, particularly today, it is said that it is very rare things. But it is not that rare also, because our young presenters, you will find that they themselves have detected this in their course of their own practice and treated this. It's not that uncommon, which your mind doesn't know, eyes won't see. So if you get sensitized, probably you will detect some cases and go ahead with this. Thanks, everyone. And I am not taking everybody's name repeatedly. I am grateful to all of you for inviting me here, and particularly the office bearers of IIP Raigad, Maharashtra, and Andhra Pradesh. Thank you very much.
Thank you, sir, for your blessings and your kind words. Now I request Dr. Pavan Kalyan, sir, who is our distinguished guest and expert for today's session, to share his thoughts and guide us further. Over to you, sir. Dr. Pavan Kalyan, sir.
Dr. Pavan Kalyan, sir, please unmute.
Madam, just 2 minutes. My son is crying, he's not allowing me. I'll just.
Yeah, okay, we will go ahead. Yeah, no issues, sir.
So, I request Dr. Jay Bhandarkar, sir, Maha-IIP State Convener, to introduce our first expert for today's topic, Dr. Mrs. Reena Zaibai, Madam, for today's first topic, pediatric antiphospholipid syndrome, who will be presented by Dr. Raju.
Thank you, Dr. Swati. And I first thank Dr. Reena for accepting to come as an expert for this important journal session today. So she's a MBC in pediatric from CMC Vellore, very well-known institute, and at present is practicing as a consultant rheumatologist and immunologist in Navi Mumbai. And she's had advanced arthritis and rheumatology clinic at Kharghar, New Bombay. And she's attached as a consultant of Medicover Hospital, Navi Mumbai, and as well as MG Hospital, Vashi. Thank you.
Thank you. Next slide, please. First presenter, yeah.
I should introduce him. Yes. So our first presenter is Dr. Swas Raju K. He is MBBS from Vinayaka Mission Medical College, Karikal, Puducherry, and this is from the Christian Medical College Hospital, Vellore. And currently working as a consultant at the Puthija Multi-Specialty Hospital, Visakhapatnam, and he's a current executive board member at the IIP Visakhapatnam, 2022. Over to Dr. Swathi.
Dr. Raju, please start.
Good evening, ma'am. First of all, I thank everyone for the kind words for welcoming me, especially Dr. Hemant sir and Dr. Dhananjay sir. They have been addressing me as sir. Sir, I'm very, very junior to all of you. If you called me by my name, Raju, I'd be more than happy. And I thank you, everyone, for your kind words in welcoming me. We'll start the presentation. So, good evening, everyone. My topic, I will be talking about pediatric antiphospholipid antibody syndrome. The general notion is that APS is rather rare. So today I'll be talking about a review article that has been published in January 2021. I would have failed in today's duty if I would not have made you at least brush at least a few points through this session today. So in my way, in order to achieve that, I would like to brush your already skills in APS through a small true or false statements. There are 6 statements. My goal is by the end of the session today, we'll finish what it is. You need not tell anybody, you need not just know the answer to yourself. If I'm clear in that, I'll be putting out the statements just to your own knowledge, just know whether it's a true or false statement. The age cutoff for pediatric APS is anywhere between 16 to 21 years. If that is true or false, whatever your knowledge is saying so far. The next one is the only antibodies that are checked in a suspected case of antiphospholipid antibody syndrome are lupus anticoagulant and anticardiolipin. Whether that statement is a true or false. The next thing is not all children with positive antiphospholipid antibodies show vascular events. Vascular events are the thrombotic events that we are talking about. The next statement is in comparison to lupus anticoagulant, anticardiolipin is considered as the most predictive test. When these both antibodies are tested, the statement says ACL is considered as most predictive test. Do you think it is true or false? The next thing is antiphospholipid syndrome can have thrombocytopenia as a part of its clinical symptom. Okay, is it possible or not? Then even other autoimmune diseases like SLE and JIA can have a antiphospholipid antibodies positive. But do you think whether this is a true statement or not? The last but one statement, treatment of thrombosis in APS includes short-term heparin until the acute event settles. The last statement is a child can have clinical manifestations of APS, but negative conventional APL tests. So through the course of this today's session, we will see what about the statements about your current knowledge and how it is mentioned in the current review article. So APS is basically an acquired systemic, it's an autoimmune characterized by arterial and venous thrombotic events associated with pregnancy morbidity and persistently positive antiphospholipid antibodies. In children, because pregnancy is a very rare situation, the criteria for diagnosis are different. Generally, the pediatric APS is considered as the one which presents before the age of 18 years. In my whole session, anything that is mentioned in green are the statements that I've talked already. So this is the first statement that I want to make clear. There is no clear-cut cutoff for age in pediatrics. Some authors say 16 or 21 years. So the initial statement which I said, that is the one. Then the criteria to diagnose pediatric APS, there are no universally accepted validated criteria. So criteria for adult onset are applied to pediatric populations. So for the adults, in 2006 Sapporo classification was mentioned, but let me tell one line that one clinical event and one persistently positive antiphospholipid test is necessary for the diagnosis of APS. So in the clinical events, it can be either of the vascular thrombosis, it can be arterial, venous, or small vasculature, and or pregnancy morbidity. In persistently positive antiphospholipid tests, the initial knowledges, at least during a few years back, was somewhere that we have to test for lupus anticoagulant and anticardiolipin antibodies. But now the current study, current research, current articles mention that there is one more thing that we need to concentrate upon, one more antibody that we need to check, that is the anti-beta-2 glycoprotein 1, either IgM or IgG, which is usually more than 99 centile. The classification that I told in one slide earlier, the Sapporo classification, it cannot be extrapolated to children because everything on your left-hand side in the tabular column, the prothrombotic risk factors, the thrombotic events, thrombosis, pregnancy, everything is common in adults, not in children. So this Sapporo classification rules out these diseases, and that we cannot extrapolate to children. That is what mainly I wanted to sell. And rather than thrombosis, there is some thrombocytopenia, hemolytic anemia, and other features which are there as clinical in the clinical spectrum while diagnosing APS. APS can either be primary or secondary. Primary, as the name indicates, is isolated. Secondary is when it is secondary to any autoimmune disease. It is equally distributed. Males and females are equally affected. Sometimes the primary APS can go on to become secondary APS. There was a study there is a register for antiphospholipid syndrome children. That's the largest register we have. In that, they said secondary APS, most likely diagnosis that precedes this was systemic lupus, systemic SLE. The next in line is autoimmune thyroiditis. So basically, I want the thing that I told recently, that beta-2 glycoprotein 1 is the main antigen. I'll not go into details of pathology. Just know that beta-2 glycoprotein antigen is against which the autoantibodies are forming. It's generally a 5-domain structure. We are not going into this. And generally, please follow the cursor. This generally, when exposed to any oxidative stress state or stress, this circular beta-2 glycoprotein becomes this one J-shaped thing. Sometimes, because of changes in oxidation glycosylation, there are neoepitopes formed, because of which autoantibodies are stimulated. So the pathogenic mechanisms of antiphospholipid syndrome, just know that this beta-2 glycoprotein 1 is expressed on many of the cells like monocytes, and all these are there. These antibodies go on to act with each with the beta-2 glycoprotein in each of the above mentioned the various cells in the body, including the coagulation factors and the complement system. So because of that, this thrombosis vascular events happen. Sometimes, in spite of APL positivity, why only occasional vascular events? That is the point when second hit hypothesis, second hit is necessary. That is, a pre-treatment with lipopolysaccharide, etc., will come into play. The clinical relevance of APL tests, taking beta-2 glycoprotein 1 as the main antigen, all tests are being conducted. So generally, lupus anticoagulant is universally regarded as the most predictive test. It's not the cardiolipin. It was one of the statements in the initial slide. So it is not cardiolipin. Lupus anticoagulant is usually regarded as the most predictive test, while ACL positivity displays very low specificity, but it has a very good sensitivity. Generally, with repeated positive rates, then we can think that the child is at increased risk. The current trend is, current research is towards risk stratification among these two specific APS bar PT antibodies and anti-D1 antibodies. So clinical manifestations. So basically, thrombotic events like for adults, but in children, there are non-criteria manifestation. That is, the clinical manifestations are not pro-thrombotic, but they have an association with APL positivity. Those are called the non-criteria manifestations. Then there is catastrophic APS. That means very catastrophic events happen. And thrombotic events, venous or arterial. Generally in venous thrombosis, lower limb DVT is the commonest. Arterial thrombosis, ischemic stroke is the most commonest. And the recurrence rate of thrombosis is approximately 19%, and it happens generally in the same vascular area in which it has happened before. Non-criteria manifestations we have talked about that they are not generally included in they are not the thrombotic events. It can be anything, hematologic, neurologic, dermatologic, any of these systems can be involved. Generally in hematology, there is enhanced platelet consumption, which is the reason for thrombocytopenia. That brings us to one of our statement that yes, thrombocytopenia can be in the clinical spectrum of APS. Catastrophic APS, it's a systemic inflammation. It happens within a week, 3 or more organ involvement. It can either be definite or probable based on preliminary classification. It is very less common in children. And so regarding other diseases, other rheumatological diseases like JI and SLE, generally anticardiolipin is the most commonly found antibody that is positive in this diseases. In JIA, very rarely events have been seen, but in SLE, arterial thrombus have been seen in children with ACL positivity. So these are the main risk factors for arterial venous thrombosis, like I told. And regarding treatment, initial therapy is the same. Like any thrombotic event in your pediatric practice, you start with anticoagulation with heparin. It can either be a low molecular weight or unfractionated heparin. Evidence for treatment of non-criteria manifestations is limited, so you treat symptomatically whatever symptoms occur. Suppose if there was thrombocytopenia, symptomatic thrombocytopenia rather than moderate to mild thrombocytopenia, you do not treat mild thrombocytopenia. Symptomatic thrombocytopenia you treat like ITP, and autoimmune hemolytic anemia you give high-dose corticosteroids and immunosuppressants. Then there is a European society called a single hub and access point for pediatric rheumatology, which recommends in children with APS to be treated with anticoagulation, corticosteroids, and plasma exchange with or without IVIG. Rituximab and isolizumab are being tried in catastrophic APS. Prophylaxis generally, they are saying based on your APL antiphospholipid profile, you decide whether single antibody is positive, triple positive. Based on that, adults have been given prophylaxis. Low dose aspirin is given. But in children who are generally more active, bleeding risk during plays and sports, long-term prophylaxis is generally not recommended. But if the child was to go to for surgery, or if any other, he had a fracture and he is immobilized for a long time, in that cases, you can give prophylaxis with low molecular weight heparin. So how do you apply this review article in common pediatric practice? Just know that children positive for APL tests are often present with non-thrombotic events. It necessarily need not mean that they should have a vascular event. They can have non-criteria manifestations like mentioned earlier. Seronegative APS, that is a term which includes clinical manifestations of APS. He has a thrombosis, he has this vascular events, but negative antibody tests. So both are positive. Tests being positive, but no symptoms. Symptoms being positive, but no tests. Both are positive, both are there. And we should be aware that such entities exist. Suppose if a gynecologist has referred a child to us saying that there is this child who's been exposed to in utero APL, that is a mother was APL positive, please follow up the child in the long term for looking for developmental disabilities. So just know that there is no difference in acute treatment of thrombosis. It's the same all over. And the recommendations are, it is not a short-term treatment with anticoagulation, like mentioned in the statement earlier, true or false statement. It is a long-term anticoagulation therapy that needs to be given to the child. So coming back to this is the last part of the lecture. So age cutoff for pediatric is anywhere between 16 to 21. Yes, that's a true statement. The only antibodies that are checked in suspected case of APS are not only LA and ACL. You also check for anti-beta-2 glycoprotein 1 antibodies. So then not all children with positive antiphospholipid antibodies show vascular event. That is true. They need not show thrombosis everywhere. In comparison to LA, ACL is considered most predictive? No. Lupus anticoagulant is the one which is considered as the most predictive test. So antiphospholipid syndrome can have thrombocytopenia? Definitely yes. Even other autoimmune diseases like SLE and JIA can have APL positivity? Definitely true. A treatment of thrombosis in APS includes short-term heparin until acute event settles? No. You give long-term low molecular weight heparin. A child can have clinical manifestations of APS but negative tests? Yes, that is also a true statement. That concludes my session now. Thank you.
Thank you, Dr. Raju, for a wonderful presentation. Ma'am, shall we take question answers right now?
No, we will ask Dr. Reena for expert comments.
Okay.
Thank you, ma'am. Thank you, IAP, to give me an opportunity. So thank you, Dr. Raju, for very crisp and informative presentation. Antiphospholipid syndrome in children, like many other rheumatological disorders, remain underdiagnosed. And there are very many gray areas in the treatment due to limited data in children. As compared to adult population, pediatric patients with APS are present with more unusual manifestations, and acute events are more common, such as catastrophic APS. So if we diagnose on time, these children respond beautifully, and we need to diagnose more and early, and treatments also to be recorded, because the data for the disease is very limited. Thank you.
Yeah, we will start the second part now, as it is already 9:31.
Yeah. Now I request Dr. Vikas More, sir, Vice President IIP Raigad, to now introduce our second expert for today's session, Dr. Pavan Kalyan, sir, for the next topic, lung involvement in rheumatological diseases, to be presented by Dr. Uday, sir. Over to you, Dr. Vikas, sir.
Is Dr. Vikas More present?
Welcome, Dr. Kalyan, sir.
Yeah. You go ahead.
You can
Dr.
share
Neha.
your thoughts.
Dr. Neha. I think Dr.
Yes, ma'am.
Vikas has not joined.
Shall I?
Yeah.
Swati ma'am, please continue. CV is already shared.
Dr. Pavan is excellent faculty, and we have heard him many times in our webinar in COVID times, and he is having sleep medicine expertise also, along with pulmonology, and recipient of various awards. And he was member of DIP, he is member of DIP academic committee, and he is practicing in Vijayawada. The next presenter is Dr. Uday. Please share his CV. He is also a star student and has done MD Pediatric in AIIMS, Karnataka, having FPCC Fellowship in Pediatric Critical Care. He is practicing he has done diploma in asthma and allergy in CMC Vellore, and presently he is a practicing pediatrician and doing work for underprivileged strata of the society. Over to Dr. Uday for his presentation. Please proceed.
Dr. Uday, you may start, please.
Yes. Good evening, everyone. At the outset, I would like to thank the organizing committee, IIP Raigad, for giving me this great opportunity to be over this platform this evening. And to start with this research article, lung involvement in children with newly diagnosed rheumatic disease, characteristics and association. This was published in the BMC journal by Hyo Hyun et al. From the Pediatric Rheumatology, published in 2022 August. To start with the background, rheumatic diseases, these are a group of immunologically mediated inflammatory disorders affecting multiple organs. Albeit rare, pulmonary diseases can occur in nearly all pediatric rheumatic conditions. These systemic inflammatory diseases with the highest likelihood of pulmonary involvement are juvenile SLE, the scleroderma, juvenile dermatomyositis, mixed connective tissue disease, and juvenile idiopathic arthritis. These pulmonary complications such as the pleuritis, the parenchymal diseases, the interstitial lung disease, pulmonary artery hypertension, either obstructive or restrictive lung diseases, are less frequent in childhood when compared to the adult. But still, once they occur, it can cause a great functional impairment and increased mortality. These reports are scarce. Having said so, this is the main motto of our article. The study aims to compare the pulmonary involvement in newly diagnosed treatment-naive patients of rheumatic disease and investigate the characteristics and associations between lung involvement and rheumatic disease. Now moving on to the methods, this is a cross-sectional study which was done between January 2019 and June 2021. It was done in the Department of Rheumatology and Immunology of Shanghai Children's Medical Center, the School of Medicine from Shanghai Jiao Tong University. Coming to the inclusion criteria, these were the patients who have been recently diagnosed with rheumatic diseases and not on treatment till now. So who have been diagnosed for the first time. In this present study, the cases were around 48 pediatric patients with lung function tests and HRCT findings, and the controls being 51 age-matched healthy controls based on only pulmonary function tests. So these controls have not been on HRCT. And coming to the exclusion criteria, the history or clinical findings of respiratory infections at the time of study, those who have already had chronic pulmonary disease such as asthma or heart disease, such patients were excluded from the study. And these disease classification, the SLE, JAA, have been already under this following classification criteria. These diseases have already fulfilled these criteria. For example, the SLE should fulfill the criteria of American College of Rheumatology, the JAA, the International League of Association for Rheumatology, and so on. And once this data has been collected in the following format of age at the diagnosis, the sex, height and weight, the duration between the disease onset and diagnosis, the history of cigarette exposure, that is passive smoking, and the clinical data, including the levels of acute phase reactants, that is ESR, CRP, rheumatoid factor, ANA, interleukins, tumor necrosis factor, CD4 CD8 ratio, and vitamin D3. Once these data have been collected, they have been evaluated with pulmonary function tests and HRCT. As I said previously, HRCT was done only for the cases and not for the controls. And these lung function tests, the maximum vital capacity, forced vital capacity, FEV1 and FEV1 FVC ratio, the lung diffusion for carbon monoxide, and FEF 25 to 75, that is a mid-airway disease, were recorded. And the main respiratory functional parameters was recorded as a percentages of the absolute measured value by predicted values. And this lung diffusion capacity for carbon monoxide, if it is less than 80, it is deemed to be abnormal. And it is again graded as mild, moderate, severe based on these percentages as given. So in the lung function test, each measurement was repeated at least thrice, and the highest acceptable measurement was compared with the normal predicted values. And these were the classified for this pulmonary dysfunction. For the restrictive dysfunction, the vital capacity less than 80%, obstructive as FEV1 or FEV1 FVC ratio less than 80%, and for this isolated impairment of diffusion capacity as DLC less than 80%. So we can easily remember it as all less than 80% of the predictive values. It is defined as this pulmonary dysfunction. And coming to this HRCT, 2 senior experienced radiologists were blinded from this study, and the HRCT findings were ground glass opacity, consolidation, septal thickening, honeycombing nodules, effusions, and progressive volume loss. And the statistical analysis were univariate and multivariable logistic regression analysis were used for the odds ratio, and all these statistical analysis were performed using this IBM SPSS software, and the statistical level significance was set at p-value less than 0.05. Coming to the controls, the clinical characteristics were tabulated under these following variables. Around there 47 of the patients were with the rheumatic disease, and the controls were 51. Out of these variables, age, gender, height, and the weight, were statistically insignificant. if we see, only the respiratory rates were significantly higher when compared to the controls. And this is even statistically significant. So compared with the controls, asymptomatic patients had a significantly higher respiratory rate on physical examination. Even though we can see the values, this is not even that high. Even these are stable values. Coming to this lung function test parameters, if we can see, the FEV1 by FVC ratio is little higher in the patients with rheumatic disease when compared to the controls. And this is even significant p-value. The rest, all the other variables in the patients with rheumatic disease has a little lower values compared to the controls. So this FEV1 by FVC was significantly higher in the groups with rheumatic disease than in the control groups. Coming to this abnormal lung function test, here we can see this lung diffusion for carbon monoxide was significantly reduced in around 40% of the cases below the lower limit of normal value. And even in the control group also, there were around 6 cases who are having a decreased DLCO, and this is significantly because the p-value is less than 0.05. And the rest, all the other variables, the vital capacity, FVC, FEV1 were statistically not significant. Coming to these characteristics of this HRCT findings, if you can see here, the abnormal thoracic HRCT was observed in around 8 of the 48 patients. And if you can see, almost all the patients were significantly female. So this gender plays a significant character over here. And out of these 8 patients, 2 were SLE, 4 were juvenile dermatomyositis, and the rest were Sjogren's and JIA. And if you can see, these are the CT abnormal findings. Out of these, 4 of the 8 patients also had PFT abnormalities. Here we can see mild reduction of this DLCO and severely restricted in around 4 of the patients. Coming to this characteristics of patients with lung involvement, we can see the pulmonary involvement. 8 of the 48 patients had abnormal HRCT findings, and 27 of 48 patients are having abnormal lung function tests. So here the total patients were 31. Out of this, 22 were female. And in these 31 patients, around 14 was SLE, 7 were JIA, and 4 were juvenile dermatomyositis. The mean disease duration from the age of onset and diagnosis around 0.25 years. And apart from that, 9 of the 31 patients had raised CRP more than 8, and 19 patients were ANA positive and 3 patients were RF positive. But having said so, only these 4 parameters were found to be statistically significant. The gender being female, disease being SLE, and the ESR and CD4, CD8 counts. These were statistically significant. And this was even proved in the univariate model study, where the gender, SLE, ESR, and CD4, CD8 were found to be statistically significant even in the univariate model as well as the multivariate model studies. Now coming to the discussion part, the lung involvement was quite prevalent among patients with rheumatic disease. Over half of the patients had abnormal PFT and or abnormal HRCT findings, even though most were asymptomatic. You can clearly see, according to the data similar to this Lilelby et al., abnormal PFT were statistically significant than the abnormal HRCT findings. So it's around 56.3% versus this 16.7%. And the most frequent pulmonary dysfunction in pediatric age group is reduction in the DLCO values and increase FEV1 by FVC ratio. Usually contrary, we expect in the obstructive disease, we expect to decrease the FEV1 by FVC ratio, but contrary here, we could see the increased FEV1 by FVC ratio and reduction in the DLCO values. And there is a good correlation between the ESR and ground glass score on HRCT. And this present study confirms that CD4 plus T cells are a correlated factor for lung involvement in children with rheumatic disease. What does this journal add to our knowledge? Absence of symptoms and normal lung function test findings cannot fully rule out a mild pulmonary involvement. Hence, PFT and HRCT should be considered. Based on the univariate logistic regression, as I said, so female sex, SLE, raised ESR and CD4-CD8 ratios was associated with lung involvement in rheumatic disease. As like every study has their pitfalls, even the present study, there are some limitations. Being a smaller sample size, study group showed significant heterogeneity. As this is one of the biggest pediatric hospital over there, there might be selection bias of illnesses among different hospitals. This is the reason why multi-center longitudinal studies are necessary to identify lung involvement in different rheumatic diseases. To conclude, lung involvement is relatively common in children with treatment-naive, newly diagnosed rheumatic diseases. Lung function tests and HRCT identify patients with asymptomatic lung involvement. Increased ESR and CD4-CD8 ratios are associated with elevated odds of lung involvement in patients. Hence, routine pulmonary evaluation recommended even in the absence of respiratory symptoms. I thank you all, one and all. And that concludes my presentation.
Thank you, Dr. Uday. Dr. Pavan Kalyan, sir, can you give your insights into the matter?
Thank you, madam. I'm sorry I couldn't say a few words, but within I'll just finish. I really thank IAP Maharashtra branch, which is very close to my heart because I did my PG from Pune. So I thank Dr. Hemant Gangulia sir and my brother Amol Pawar. And I shouldn't forget Chitra madam, who has been behind us. And I should thank both these presenters who have accepted this in a very short notice. And talking about rheumatological diseases and pulmonary manifestation, definitely it's very, very rare in the childhood diseases where we find, but as the disease progresses, you may find the pulmonary involvement. What this study tells us, you need to be a little more aggressive, but not in the form of doing a HRCT, but PFT would help. And DLCO, we don't have, much centers don't have a DLCO. So what you can best do is try to identify, because the most common things are SLE, JA and systemic sclerosis, where you need to work out. The other thing is that when you have having exacerbation of SLE, you may keeping on giving steroids. The most common thing what we feel in what we see in India is about tuberculosis. Because of the immune suppression, you may have resurgence of your TB. So you need to have a little vigilant, not by over-treating it, but whenever you feel such cases of persistent cough for more than 2 weeks, whatever NTEP guidelines is, we have to follow it so that we are not missing TB. As well as immunosuppression also causes the resurgence of TB. So we need to be little worried, basically because we are seeing more of SLE this thing. But as of now, if I have asked in both in Australia where I work, where I've been trained, as well as India, I haven't seen much of pulmonary complications with those rheumatological manifestation. But we should be vigilant in this. Thank you. Thank you, madam.
Thank you, sir.
Shall we, now I request Dr. Hemant Mohanty sir to add further insights and give us his blessings and comments. So please unmute.
Mohanty sir, please unmute.
Sorry. Rather, we thank both the presenters. They have done justice to the topics. This is a success story today to have both these topics were initially scared. Probably these topics are a bit more towards scientific. Our general pediatrician may not be interested, but you see how much discussion it has generated. And these young dynamic presenters have actually made their day. They made them very interesting. There is nothing to say about the presentation. Only thing is, Dr. Uday, can you throw some more light why this pulmonary function tests are showing higher value in the cases? Any presumption, any justification for that?
Sir, no, sir. When we are going through this article, that's what even we discussed with Dr. Pawan Kalyan, sir. I don't know why that FEV1 by FVC ratio was increased in this case. Usually we suspect to be decreased. So even we are not aware of that.
Okay, I think this is a good subject to study further. Thank you. And this day is done. We'll go look forward to more participation of people like them, like young persons from whom we have a lot to learn in our life. Thank you.
So that is the reason, sir, we don't rely on FE1 by FEC here. We see on DLCO, where DLCO is not a part.
It's not available.
Yeah, correct. It is available in some centers, but it not. The other part is, for a DLCO, we need to have the hemoglobin at least a week or at the same day, sir. So in the study, we didn't have the hemoglobin measurement. So there are little flaws in the study. So in spite of that, at least they have said that even though there are rare complications, you need to have a vigilant eye. That's what they have told us, sir.
Yeah, that's great. That's right. Thank you.
Yes, sir. The whole idea of presenting these papers were to increase the awareness about the problems.
And the shortcomings of these studies has to be highlighted in journal clubs. The strength of the study as well as the weakness of the study, we need to understand and realize. Suppose you have to conduct another study of similar nature, you will learn the lessons from the previous studies. It should go in our mind. Thank you.
Over to Dr. Jay. Any questions in the chat box?
एक मिनिट बघतो मी आहेत का. No questions in the chat box.
YouTuber questions nahi hai.
Okay, thank you. My question to Dr. Pawan sir, that do biologicals also warrant these things like steroids, what you just said?
Madam, biologicals, we don't generally, we don't see, madam, because SLE, I haven't, because in my whole practice, even though I've seen SLE, I haven't seen people using biologicals coming with pulmonary involvement because they would be presenting it late in morbidity and mortality. So I don't have much experience right now because I haven't looked into the studies. I'll just look into whether the biologicals, but as of now, nobody mentioned about TB also, even though I've looked into the literature, because they said that the pulmonary involvement is less, and that too the ILD, pH, those are the things they have mentioned. Because we don't see in the Western world, whatever, we have seen this ILD and the CT scan changes, but not of TB. So I don't think much of biologicals have been studied for this one.
Thank you, sir. Over to Dr. Swati.
Thank you, everyone, and especially the presenters, Dr. Uday and Dr. Raju, sir, for painstakingly making such interesting slides and making such difficult topic easy for us. And Dr. Pawan Kalyan, sir, Dr. Reena, madam, Dr. Niman Mohanty, sir, and all the presenters and dignitaries, and all the colleagues who have been patiently listening to the presentation. Thank you, Chitra ma'am, for organizing it and putting together.
I want the thanks from Raigad IIP Secretary, Dr. Dhananjay Rajpur.
Sure, ma'am. Thank you. Thank you very much. It was a wonderful section of General Journey.
Doctor, you are not audible.
Your voice is
Dr.
not
Dhananjay?
Yes, just a second.
There is some connectivity issue, I think, Dr. Dhananjay.
I think the.
Am I audible?
He is not.
Yeah.
Okay. So this was a wonderful section of General Journey. As always, this is our last session of General Journey of this year.
You're not audible still. So you're not audible. Your audio is not clear still.
Oh, sorry.
Yeah, but the emotions are conveyed.
Yeah.
So thank you, Mohanty sir, who is our guest of honor today and who is our guiding force behind this General Journey. I would like to thank our experts today, Dr. Nida Zaibhai madam and Dr. Pawan Kalyan sir, for their expert opinion and expert inputs. Thank you very much, both of you. I would like to thank our speakers today, Dr. Swas Raju and Dr. Uday, for their wonderful presentations. Thank you very much. Sincere thanks to our moderators today, Dr. Chitra Madam and Dr. Swati Madam. I would like to thank our Maharashtra IIP President, Dr. Hemant Gangulia Sir, Dr. Mandalkar Sir, our State Convener of Maharashtra IIP, General Secretary of MAHA-IIP, Dr. Amol Pawar Sir. I would like to thank our Dr. Wankhede Sir, Dr. IIP Raigad President, our Dr. Vikas More Sir, Vice President of Raigad IIP, and Dr. Neha Singh Madam for conducting this session. And finally, thanks to all the delegates who are patiently hearing and patiently attending this session. Thank you.
Thank you, sir.
Pallavi ma'am, stop recording.